Today I'm going to talk about something about treatment of tuberculosis. Tuberculosis as a disease, it's known since Vedic era in India as a Kshay Rog, and similar description given by Hippocrates, father of modern medicine, as phthisis. That also means the decay. And discovery, very important landmark in the history of tuberculosis, is the discovery of causative organism of tuberculosis. That is on 24th March 1882 by Robert Koch, and that's why this disease is known as Koch's disease. And the discovery day, that is the 24th March, is being celebrated throughout the world as World TB Day. And before 1943, as you know, there was no anti-tubercular drug to treat tuberculosis, and that's why before 1943 era is called pre-chemotherapeutic era. And the basics of tuberculosis till 1943 were good nursing care, good nutrition and fresh air, and the same description was given in Ayurveda. However, in 17th and 18th century throughout the world, the same kind of treatment was offered in the sanitaria, and that's why it is referred as sanitaria treatment. And then the beginning of chemotherapy era, when the new drugs came into existence for treating tuberculosis, and this was the story started in 1944. And since then we have a lot of drugs from streptomycin to pyrazinamide, and we have good success at least in developed countries. And that's why tuberculosis was thought to be a controllable disease in 1960. And WHO also thought that now it's not a global problem in the world. But what happened in 1980 and 81? There was a resurgence of tuberculosis. Why? Mainly due to HIV. And as we know that HIV is closely associated with tuberculosis. And due to this, there was a resurgence of tuberculosis. And that's why again WHO in 1993 declared tuberculosis as a global emergency. So that's another important landmark in the history of tuberculosis, the year 1993, when tuberculosis was declared as a global emergency, my dear friends. Why? Because of the three reasons. And what were the three reasons? The rising problem globally association with HIV and increasing the problem of drug resistance. And still in 2016, we are facing this problem of increase in drug resistance. And if you see the global burden throughout the world, there's roughly 9.6 million cases of tuberculosis in 2014, and roughly 15 lakhs out of this 1 crore population of tuberculosis died because of tuberculosis. So roughly you can say that 15% mortality due to tuberculosis. And if you see the scenario of drug resistance problem, the multi-drug resistance problem, roughly there are cases around 4,80,000, and roughly death is also 1,90,000. So if you see the death in MDR cases, it is roughly 1/3. So 15% of tuberculosis cases, the sensitive TB, overall TB, they are dying, but MDR cases, the mortality is 33%, of roughly 1/3 people dying. So in mortality in MDR TB is little bit very high rather. So what is the success story of TB treatment? How everybody want the successful treatment of tuberculosis, rather every disease. You also want, we also want that our patients should be treated successfully. So what is the success story of tuberculosis? I used to describe by 4 C's. What are these 4 C's? If you search the literature, if you search the internet, you will not find such a mnemonic 4 C's in the tuberculosis. But this is my personal way of teaching. For your simplicity, the 4 C's for the success of a story of treatment are: the first C, that is correct diagnosis, second C is the correct categorization, third C is the correct prescription, and fourth C, last but not the least, is the compliance. So we will discuss one by one. So coming to the first C, that is the correct diagnosis. How do we approach for correct diagnosis? Diagnosis of pulmonary tuberculosis or extrapulmonary tuberculosis, basically it's a clinician's, physician's prerogative. Of course, important test is the bacteriological test that is supposed to be the gold standard for the diagnosis of pulmonary tuberculosis. What is the place of X-ray or radiology in the diagnosis of pulmonary tuberculosis? I used to say my student and various forum, sensitivity, or you can say the specificity of X-ray in the diagnosis of pulmonary tuberculosis is only 50%. So if you are making diagnosis of pulmonary tuberculosis on the basis of X-ray alone, the chances are that you are 50% correct and 50% wrong. So don't rely too much on radiology as far as the diagnosis of tuberculosis is concerned. And of course, this is the era of molecular diagnosis. So you have to utilize the molecular test, the GeneXpert, a Hens test, and of course, this is the gaining today importance in the diagnosis of tuberculosis. And that's why if you see the WHO current policy recommendation for the diagnosis, that you can use the liquid culture since 2007, the line probe assay, Hens test 2008, since 2008, and of course the latest but very important test, the GeneXpert for TB, also recognized by WHO and for Government of India also in RNTCP program also. And so since 2010 we are using this test, GeneXpert for TB, and it's a very useful test. And coming to the second C of the story of success of the TB treatment, that is the correct categorization. Very important. You see, categorization of your patient, whether fitting into the category 1, 2, 4 or 5, it's very important. And what you need before categorization, there are certain prerequisites, and these prerequisites are, you must know the site of disease. I am dealing with pulmonary or extrapulmonary. Whether it's a bacteriological confirmed case by smear for AFB, by culture of AFB, or by CBNet. So it's a simple smear examination, culture examination, or one molecular test, the CBNet. Or it's a clinical diagnostic test, whether it's a clinical decision to treat TB, whether it's a histopathological proven or radiological proven, all clubbed together, and this comes under the purview of the clinical diagnosed TB. And of course, you must know the previous history of treatment, it's a very important. And most of the time patient hide the story of previous treatment, but you have to explore it. So whether it's a new case or old case, if there is a history of no ATT prior, it is new case, or there is a history which is less than 4 weeks duration, it is a new case, otherwise it's an old case. And of course, you must know according to the recent WHO guidelines as well as the Indian guidelines for tuberculosis, you must exclude the HIV and diabetes status of the patient to whom you are going or planning to treat tuberculosis. Now, this is the categorization algorithm. So, new case is categorized into category 1, old case ATT more than 1 month history categorized into category 2 when it's a category 1 relapse or defaulters. Category 2 failure, they are usually MDR TB coming into the purview of category 4, and of course category 4 failure into category 5. So, next C, that is the third C for the success of TB treatment, is the correct prescription. How to prescribe correctly the treatment of tuberculosis. And before that, you must know what are the basis of chemotherapy. So, this is the short course chemotherapy which we are practicing nowadays, and the basis of chemotherapy are two: the bacteriological basis and pharmacological basis. The bacteriological basis usually due to naturally occurring drug resistant mutants. We know that there is a natural mutation of the Mycobacterium tuberculosis, and of course existence of subbacillary population. We will discuss right now what are the subbacillary population. And of course, the pharmacological basis is that ideally administration of all drugs at the same time to achieve the peak serum concentration. So, this naturally occurring drug resistant mutants, that's why we divide the treatment into two: intensive phase and continuation phase. And subbacillary population, as we know, that the slowly growing bacteria, fast growing bacteria, and of course the dormant bacteria. And what are the various anti-tubercular drugs acting on various type of subpopulation? If you see extracellularly rapidly multiplying drugs, the INH, rifampicin, streptomycin and ethambutol, they are working on this subpopulation. If you see rifampicin specifically, this is also working on extracellular slowly multiplying bacteria. So, this is the only drug which is working against the slowly multiplying bacteria, and that's very, very important for the, of course, the success of the treatment. And of course, pyrazinamide, this is working against the intra and extracellular acidic environment. That is the limitation of the pyrazinamide, that it works only in acidic environment. And to begin with, there is a lot of inflammation in tuberculosis and environment is acidic, and that's why it is given in intensive phase, not in continuation phase. So, that is the reason that why pyrazinamide is used in intensive phase only. And C, there is a subpopulation called dormant population. And my dear friends, no drug is working against this dormant population, and probably that's the reason the success of the Mycobacterium tuberculosis, that still it is surviving after a lot of centuries and years. Now, last C for the success of a treatment is the correct prescription. Rather, it is third C. So, prerequisite for correct prescription are: the weight of the patient must be recorded, health education regarding disease, infectiousness, toxicity of drugs, and social behavior. You see, this tuberculosis in this country is still a social taboo. And due to this social taboo, patients are being isolated, their utensils are being isolated, their clothes are being, towels being isolated, room being isolated, and this should not be done. Basically, tuberculosis patient also a human being. So this social behavior aspect should be given to the patient and attendant. And motivation for regular and complete treatment, prescription according to the category which we have discussed right now. And this is the correct prescription category wise. In category 1, you have to prescribe for 2 months of ethambutol, INH, rifampicin and paracetamide, and you can replace streptomycin in certain cases, for example, in tubercular meningitis. And continuation phase, you can give the 4 months of INH, rifampicin and ethambutol, and the same combination, same drugs can be given on intermittent basis thrice weekly in DOTS, the current policy, but in DOTS also now the policy is being changed. It will change rather, and now we are shifting, India is shifting from intermittent therapy to the daily regimen. And for category 2, the 2 months of streptomycin, INH, rifampicin, ethambutol, paracetamide, followed by 1 month of INH, rifampicin, ethambutol, paracetamide, followed by 5 months continuation phase of INH, rifampicin and ethambutol, and of course prolongation of the 1 month of INH, rifampicin, ethambutol, paracetamide or intensive phase can be done depending upon the clinician decision. And similarly, the category 4 and 5 regimens, which are the regimen for drug resistant cases. In this slide, you can see the patient wise boxes. So the whole box is there just to ensure the availability of drugs throughout the time period of the treatment, and that's why there is no default from the government side, from the administration side. And just to comply the regular treatment and complete treatment, the patient wise boxes are there. And you can see this is the patient identity card which is being filled and given to the patient in DOTS program. And there are certain special situations where you require a special kind of attention for treating tuberculosis. The first and foremost condition is the TB and diabetes mellitus. Now, how will you treat this combination? Now, this is my review article, Diabetes mellitus with pulmonary tuberculosis are double trouble, published in Journal of Indian Medical Association in 2014. You can go through this article. This is a wonderful disposition of the various kind of interaction between tuberculosis and diabetes. And then in patients of TB aged more than 18 years, this is the government order regarding this, that diabetes screening is essential. So any patient to whom you are diagnosing pulmonary tuberculosis or to whom you are suspecting pulmonary tuberculosis, diabetes screening must be done. Treatment of tuberculosis and diabetes is no different from treatment of tuberculosis and non-diabetics. So the drugs, regimen and everything remain the same. The only thing is that you have to control strictly tuberculosis. So the principles of management of coexisting diabetes, TB and diabetes comprises: number 1, proper care and hospitalization in patient with poor diabetic control. Ideally, insulin should be used to control blood sugar during anti-TB treatment. However, oral hypoglycemic can be used if the patient is well stabilized on them. Drug interaction with rifampicin need to be kept in view and recognized if they occur. Glycemic equilibrium is essential with goals of maintaining fasting blood sugar less than 100 mg/% and glycosylated hemoglobin less than 6%. Monitoring for adverse effects, particularly of hepatic and nervous system, should be done as it may lead to peripheral neuropathy, and use of potentially neuropathic agents in patient with peripheral neuropathic demands special consideration and administration of pyridoxine. Now, another situation which you usually encounter in your day-to-day practice is the TB and pregnancy. So, TB treatment and pregnancy, this is untreated tuberculosis disease represents a greater hazard to a pregnant woman and her fetus than does it treatment. So, you have to treat tuberculosis in pregnant lady. Infants born to women with untreated TB may be lower birth weight than those born to women without TB, and in rare circumstances the infant may be born with TB. Although the drugs used in the initial treatment regimen for TB crosses the placenta, they do not appear to have harmful effects on the fetus, so you can use almost all the drugs except a few which I will discuss right now. So, for TB disease, the same regimens are recommended for use in pregnancy as for the non-pregnant state except for withholding of streptomycin. Streptomycin, you should try your best that you should not use it. Currently, the DOS strategy is being increasingly used worldwide for the pregnant women having TB. Supportive measures during ATT administration includes an intake of pyridoxine with isoniazid during the entire period of therapy to prevent peripheral neuropathy, as being practiced under RNTCP also. Prophylactic vitamin K administration to baby at birth for preventing hemorrhagic disease of the newborn. Bleeding attributed to hypothermia has been reported in infants and mothers following the use of rifampicin in late pregnancy. And the third issue of using anti-tubercular treatment in breastfeeding women. Breastfeeding should not be discouraged for women being treated with first-line anti-tubercular drugs because the concentration of these drugs in breast milk are too small to produce toxicity in the nursing newborn. So, breastfeeding is safe in all patients on treatment of tuberculosis. Under RNTCP, breastfeeding of neonates is recommended regardless of mother's status. Treatment of tuberculosis in liver dysfunction, very common entity in this country, that patient presenting with tuberculosis and having liver disease or during treatment develop liver disease. In the patient with end stage of advanced liver disease, liver function test should be done at the start of the treatment. If SGPT level is more than 3 times the upper range of normal with symptoms or more than 5 times upper range of normal without symptoms, the following modified regimen should be considered. There are 3 types of regimen usually recommended for the tuberculosis with hepatic dysfunction. The first type of regimen, group A, that contains the 2 hepatotoxic drugs, 9 months of rifampicin, INH, ethambutol. 2 months, second regimen is 2 months of streptomycin, INH, ethambutol, rifampicin, followed by 7 months of isoniazid and rifampicin, and of course 6 to 9 months of 3 drug combination, that is rifampicin, ethambutol and pyrazinamide. The second type of regimen is the group B, containing 1 hepatotoxic drug, that is 2 months of streptomycin, INH, ethambutol, followed by 10 months of INH, ethambutol. The third group is containing no hepatotoxic drug, very safe, that is 18 to 24 months of streptomycin, ethambutol, quinolone. So, streptomycin will be withheld within 3 to 6 months and later on it will be followed by ethambutol and quinolone. Another important condition, that is treatment of tuberculosis in renal diseases. So, TB patient with renal failure, patient having chronic kidney disease are at increased risk of developing TB. Any patient with active TB, pulmonary or extrapulmonary, should receive adequate standard ATT, albeit with low dose interval modification whenever necessary. So, you can use any anti-tubercular drug, but for certain drugs you have to use with low dose with frequent intermittent intervals. Isoniazid and rifampicin, 2 important drugs of first line drugs, very safe, primarily have hepatobiliary clearance, that is why very safe for renal disorder and need no dose adjustment. There is a significant renal excretion of ethambutol and pyrazinamide and therefore its modification is necessary. Patient with stage 4 and 5 chronic kidney disease and on hemodialysis, dosing interval should be increased to 3 times weekly for ethambutol and pyrazinamide. While giving isoniazid and severe renal insufficiency, patients should also receive pyridoxine to prevent peripheral neuropathy. And the dose adjustment, if you see, this is required. For example, isoniazid, no dose adjustment required. For rifampicin also, no dose adjustment is required. Pyrazinamide, 25-35 milligram per kg per dose 3 times per week. So, not daily. Ethambutol, 15 to 25 milligram per kg per dose 3 times per week. Rifabutin, normal dose can be used. Rifampicin, no adjustment necessary. Streptomycin dose adjustment is required. 12 to 15 milligram per kg per dose 2 or 3 times per week. So, not daily. Similarly, with capromycin, amikacin and kanamycin, the dose is given 3 times per week. And similarly, with ofloxacin, the dose is 3 times per week. For levofloxacin also, the dose is 3 times per week. For moxifloxacin, the dose adjustment is not required. And for the terazidone, recommendation not available. Prothionamide, no adjustment. Ethionamide, no adjustment required. And para-aminosalicylic acid, it pass the 4 gram per dose twice daily, maximum daily dose can be given. For betaquilin also, no dose adjustment required. For linezolid also, no dose adjustment required. Clofazimine also, we don't require any dose adjustment. However, for amoxicillin clavulanic acid, depending upon the creatinine clearance, we can recommend it twice daily. For imipenem and celastin, we required dose adjustment according to the creatinine clearance, and same for the meropenem and high dose isoniazid. So, this is the dose adjustment with renal impairment with all anti-tubercular drugs. Now another situation, special situation, TB and HIV, very important situation. This is also considered a very double trouble problem in our country. And treatment of TB is same as that in HIV negative TB patients. So here also you don't discriminate the treatment between HIV positive and negative. HIV infected patient must be provided access to care and support for HIV disease, including antiretroviral therapy. All non-HIV infected TB patients are to be provided access to counseling and testing. And what is the role of ART? If you see, this antiretroviral therapy prevent reactivation of latent TB in HIV infected. So in HIV infected with mycobacterium tuberculosis, and this should be started, and of course the benefit is that it prevents the reactivation of latent TB. Reduce the short-term TB related morbidity, reduce recurrent TB, that is the relapse and reinfection cases, reduce long-term mortality after an episode of TB, and anti-tubercular treatment should be started before ART. ART should be started at least 2 weeks after ATT or maximum within 2 months. So from 2 weeks to 2 months, you can wait for the stabilization of the patient after starting anti-tubercular treatment, and later on you can start the antiretroviral therapy. So TB and NRT drug interaction, we know that rifampicin has got the, it stimulates the basically cytochrome P450 enzyme, and that's why it metabolizes the rapidly various NRTIs and protease inhibitors used for the treatment of HIV. And this rifampicin significantly reduces the bioavailability of nevirapine and the C minimum to subtherapeutic levels in 62% of patients. NRTI and protease inhibitors can enhance or inhibit this system, leading to altered blood levels of many other drugs. So we should be aware. So that's why the ART has been redefined, rechanged because of increasing cases of TB and HIV. So now this regimen is that zidovudine or tenofovir plus lamivudine and efavirenz. Previously efavirenz was not part of the ART, now efavirenz is the part of ART, just because it's a feasibility with rifampicin. So depending upon the hemoglobin, there are two regimens. One regimen is the use of zidovudine, lamivudine and efavirenz. This is preferred for patient on anti-tubercular treatment when patient having hemoglobin more than 9 gram, means they are not anemic. But if they are anemic, then of course you have to modify zidovudine with tenofovir. So we use tenofovir in place of zidovudine, and the combination is tenofovir, lamivudine and efavirenz. Efavirenz is safe for using with rifampicin, and that's why for patient on anti-tubercular treatment having less than 9 gram hemoglobin, that's who are anemic, so this regimen should be used. So these are the two important regimens used for the TB and HIV. Now a new drugs in pipeline. So as a student of tuberculosis, you must know what are the new drugs in pipeline. And you can see that a lot of groups, they are in the discovery phase, the preclinical development, clinical development, phase 1, preclinical phase, or the phase 1, phase 2 and phase 3 trials. Interestingly, the bedaquiline is the wonderful drug which is coming up. Now in India, I can expect that in 2017, probably you will be using this bedaquiline drug as a part of your prescription. And later on, we are also expecting another drug, Delamanid. So these are the two important drugs, and other we are having a long list is there. So we are waiting for the various steps of trials, and of course then field trials, and then of course for using our TB patients. In nutshell, we can say that tuberculosis is a major health problem in our country and globally too. Tuberculosis is overdiagnosed and misdiagnosed in our country, and that's why follow the treatment guidelines. Don't use your individual whimsical approach. Please read the guidelines, follow the treatment guidelines, and provide relief to our society, our patients. And that's why we can fight against tuberculosis with you by joining the hands together. Thank you very much for this lecture. Thank you.
we'll be learning something about